My name is Lindsay Bells. I am a field marketing specialist for Axonics, and I will be moderating the webinar. This evening, Dr. Unterberg will be speaking about bladder and bowel dysfunction, the common symptoms patients experience, and treatment options available that may help patients gain control. Without further ado, I would like to introduce to you Dr. Unterberg.
Thank you, Lindsay, and thank you everybody for those of you who joined me this afternoon. Again, my name is Dr. Unterberg. This is a bit of information on my bio, but essentially did my undergraduate training at University of Pennsylvania, down to Texas for medical school, locally at UCSD for residency, and then the UK in London for my 2-year fellowship that specialized in voiding dysfunction, urinary incontinence, as well as some pelvic organ prolapse reconstruction. And this is some housekeeping information as well if you would like to review about axonic sacral neuromodulation therapy and Bulkamid urethral bulking system, which we'll go into a bit more detail about those two treatment options further in the presentation. And you can also refer to the website listed at the bottom right for additional important safety information. So the point of this presentation is really to discuss a number of conditions and diagnoses that affect a lot of men and women that we see in our practice on a daily basis. And although the one nice thing with these symptoms is they're not life-threatening, they definitely can have a negative impact on quality of life, and we'll go through that in a bit more detail as well. But these are all sort of comments and thoughts that for sure many of our patients have experienced. But the good news is you are not alone, and there are a number of different treatment options available to help with the conditions that we'll discuss. So it's a very common set of conditions that we see quite commonly in our urology practice. Overactive bladder affects an estimated 50 million people in the United States, as well as 19 million suffering from fecal incontinence. And only half of those with severe symptoms seek treatment. And another condition that causes urinary incontinence, referred to as stress urinary incontinence, can affect as many as 1 in 3 women throughout their lifetime. So understanding your condition, in order to better understand the cause of some of these conditions we're experiencing, we have to understand first normal anatomy and how the bladder is normally meant to function. So normal bladder function requires storage and emptying of urine. So the bladder is an organ that passively fills with urine that drains from the kidneys, and the urethra contracts in order to hold that urine in place. And it's really only when we want to urinate is the time where the bladder actually starts to generate pressures and contract to push the urine out as the urethra relaxes, and that's how we empty our bladder completely. And similarly with normal bowel function, as the rectum fills, there's receptors and nerve signals that are sent to our brain, letting us know that we need to have a bowel movement, and nerve signals help coordinate the relaxation of the pelvic floor muscles, as well as muscles in the rectum to push the stool out. So first we have to define the problem, and there's a lot of definitions in medicine, but it's important for us to understand what these terminologies mean in order to sort of further understand the treatment options, and as well to understand the remainder of the presentation. So one condition that we commonly see is overactive bladder, and really the hallmark symptom for this condition is urgency. So it's the sudden urge to urinate. And in some cases, it's strong enough that patients can't hold their urine and have leakage. Other times, leakage isn't a problem, but again, it's really that urgency that defines an overactive bladder. Urinary retention is really the opposite side of the spectrum, where patients can have difficulty emptying or have incomplete emptying of their bladder. Fecal incontinence, similar to urinary incontinence, but with involuntary loss of stool instead of urine. And stress urinary incontinence is another common form of leakage that we see quite often, and that occurs with really any activity that increases the pressure in the belly that leads to leakage, whether that's coughing, sneezing, laughing, heavy lifting. So now that we've defined these different conditions, we'll go into a little bit more detail about what they entail and kind of commonly what we see with patients that present to our clinic. So an overactive bladder, which also is referred to as OAB, is, again, the frequent and urgent need to empty your bladder, and it can often result in unintentional urine loss. There's other symptoms that we commonly will see patients experience with this condition. That would be urinary frequency, which is defined as urinating over 8 times a day. Again, that urgency, which is sudden urge that's difficult to control and hold off. Urge incontinence, which is leakage that tends to happen in the setting of that urgency. So rushing to the bathroom, for example, not being able to make it on time and having an accident, that would be referred to as urge incontinence. And nocturia, or waking up at night more often than should be the case, is another common symptom of having OAB. What is fecal incontinence? So fecal incontinence is the uncontrolled loss of stool, and symptoms can include urge incontinence, passive incontinence, and soiling. So similar to the bladder, you can have the same thing with the bowels with fecal urgency or the sudden urge to pass stool. Urgency fecal incontinence is the inability to stop the urge to pass stool. And finally, passive fecal incontinence is leakage of stool with activity or without awareness. So finally, what is stress urinary incontinence? So again, this is leakage that occurs with any abdominal pressure. So it's not, I like to tell patients, it's not mental stress, but it's really stress to the pelvis. And so any activities such as coughing, sneezing, laughing, jumping, exercise, running, anything that really increases the pressure in the belly, that pushes down on the bladder and leads to leakage, that's referred to as stress urinary incontinence. There's a couple different reasons for it. Sometimes it can be a weakness within the pelvic floor support that allows the urethra to be too mobile. That's called a hypermobile urethra. And that mobility of the urethra can lead to leakage with activities, or there can be an issue with the sphincter muscle itself within the urethra. If that sphincter is weakened for a variety of reasons, then that also can lead to stress urinary incontinence. Now, as we discussed earlier, this doesn't affect life expectancy, but it can definitely have major ramifications on quality of life, whether it be physical limitations of certain activities, social interactions, create psychological stress or issues with mental health, sexual problems, specifically around intimacy and occupational as well as domestic impacts. All of these types of symptoms can definitely have a big impact on, and that's why it's quite important to address. And even though these conditions tend to occur in patients that are a bit older, and there are risk factors that can increase the likelihood of some of these diagnoses and symptoms occurring, it doesn't mean there's not something that we can do about it, and that we just have to assume this is a normal part of living, and therefore patients just have to live with it. So the condition is not a normal part of getting older. It's not related to just being a woman or issues with the prostate, and also not caused by something that you as the patient would have done. The good news, which we'll go into now in detail, are that there are plenty of treatment options available to help with improving the quality of life of patients and improving the symptoms that we've earlier discussed. So first off is this patient care pathway that goes into a little bit of a path of getting the results that you hope for. And obviously the first step has to be having a consultation with your physician. During that initial appointment, you'll typically discuss your symptoms, have a physical exam performed. There are some additional advanced testing that sometimes will offer to help us further delineate the cause of leakage, because it can be quite often that women and men will have multiple types of leakages happening, and we have to try and tease out which is most bothersome to focus on first. And then at that appointment, typically we'll kind of initially discuss the various treatment options for improving those symptoms. Now, although there are a number of treatment options available, typically for a number of these conditions, whether it be overactive bladder, retention, or fecal incontinence, we kind of break them up into initial treatment as well as advanced therapies. Typically, those initial therapies coincide with either medical treatments, medications, or with more conservative behavioral modifications, which also includes pelvic floor physical therapy. So some of the treatments that have pretty minimal risk, minimal side effects, we like to start with first to try to achieve improvement. But the most important thing is following up with your doctor. So we know that there's a pretty high attrition rate. A lot of patients that are started on medications who don't have benefit and just don't follow up because they get a bit disheartened and don't think there's anything else that can be done. But it is important, especially for the physician that you're seeing, to really create expectations and make frequent follow-ups to ensure that the treatments that you're being offered and starting, that they're being efficacious. And so typically when I prescribe a medication or send patients to physical therapy, I like to follow up with the patient sometime within a month or two to make sure that they're getting the benefit that they want. And if not, then at that point we would discuss advanced therapies. For overactive bladder, there's 3 advanced therapies that we'll go into more detail in just a bit. Sacral neuromodulation is one treatment option, as well as percutaneous tibial nerve stimulation and Botox injections. As you can see with both urinary retention and fecal incontinence, that sacral neuromodulation treatment pops up as well, because it really is the one therapy we have that can improve all these different conditions, with fecal incontinence having some more invasive options such as surgical sphincter repair. So to spend a little bit more time on the advanced therapies for overactive bladder, the first one is percutaneous tibial nerve stimulation, also known as PTNS. And this treatment delivers electrical stimulation provided through a needle placed above the ankle. Typically, when I see patients in the clinic, I let them know that this treatment is a little bit of a time commitment. They have to come into the clinic setting once a week for 12 weeks. And each time they come to the office, each treatment takes about 30 minutes to stimulate the tibial nerve. Generally, after those 12 sessions, if patients have noticed improvement in symptoms, then they will need to continue to return to the clinic once every month for a top-up or maintenance treatment. PTNS is about 65% successful in improving OAB symptoms without really much risk or side effect associated with it. The next option is chemodenervation injections into the bladder, or Botox. And similar to Botox in the face that helps relax the muscles to eliminate the wrinkles, the Botox injected into the bladder also relaxes the bladder muscle to help reduce that urgency and frequency. This treatment typically lasts about 6 months, so it is a procedure patients will need to come into the office on average about twice a year to have done. And it's about 85% successful, again, compared to the 65% successful with PTNS. However, there are some additional risks associated with Botox. The main one and unique to Botox is in about 5% of patients, it can actually work a bit too well in relaxing the bladder and can make it difficult to empty for a short period of time. And finally is sacral neuromodulation therapy. And again, this treatment is not only useful for helping relieve OAB symptoms, but can also help patients with fecal incontinence or fecal urgency, and even non-obstructive urinary retention. And the way this procedure works is it modulates the activity of the sacral nerve, which helps restore both bladder and bowel function. This treatment as well is roughly 85 to 90% successful, but it's a bit more of a long-term solution. The battery that we'll discuss as well, that's placed inside the patient, lasts between 15 to 20 years. So it's a treatment that doesn't require patients to keep coming back into the office to have more done to help with symptoms. And finally, for treatment options specific to stress urinary incontinence, there's a number of different treatments available, and similar to the previous treatments, there's always going to be non-surgical lifestyle changes, behavioral modification, as well as pelvic floor physical therapy and exercises that can help with stress urinary incontinence management. However, in patients where this isn't enough and they need something more done, there are more procedure or surgical options available to further help that type of leakage. One option is a surgical sling, or the mid-urethral sling, which uses a small strip of mesh that's placed underneath the urethra to provide support to help prevent leakage with increasing abdominal pressure. This is an outpatient procedure and is quite successful, 80 to 90% success rates with 17-year follow-up, and is considered by many to be the gold standard for the surgical management of stress urinary incontinence. As you can see below, this talks about women who plan to get pregnant. There are certain instances or patient factors that we take into consideration before offering this specific surgical intervention. And the last option are urethral bulking agents. There have over the years been a number of different types of material that have been injected within the lining of the urethra. And the one that we'll talk a bit more in detail about is Bulkamid, sort of the new kid on the block that has been most recently approved by the FDA in the United States, but has been available for quite some time with a lot of success and efficacy in Europe. And these bulking agents, such as Bulkamid, are injected into the wall of the urethra in order to bulk up the walls and prevent leaks from occurring. The procedure usually takes place in the outpatient setting. It can be done in the hospital or even in the clinic space, and patients are able to go home the same day. The nice thing with Bulkamid or these bulking agents is that the procedures in general are quite low risk without much recovery at all. So now that we've talked about normal anatomy, we've defined some of these conditions and symptoms that are quite common throughout the patient population, and we've sort of done a general review of the various treatment options for these conditions. We're going to now shift focus one more time to more specifically discuss axonic sacral neuromodulation as a treatment, again, for overactivity of the bladder, fecal incontinence, and non-obstructive urinary retention. And we'll go into a bit more detail about Bulkamid therapy as well. So what is axonics therapy? So sacral neuromodulation therapy is a guideline recommended therapy that restores normal control of the bladder and bowel. Axonics therapy is indicated, as we just discussed, for the treatment options of patients with overactive bladder, urinary retention, as well as fecal incontinence. And how does it work? So overactive bladder, fecal incontinence, and urinary retention may be caused by an abnormal communication between the brain and bladder and bowel. Axonics therapy provides gentle stimulation to the nerve that controls the bladder and bowel in order to help restore normal communication between these organ systems. So one of the nice things with sacral neuromodulation, which I think is quite exciting for patients that I often see in the clinic space, is that we get to do a bit of a trial run first to confirm that this treatment will work for the patient before committing them to a full implant. And this is one of the few, if not only, treatments within all of urology where we get to do this sort of test drive to see if something's going to work before put patients through the final product. So typically for the office-based trial, patients will come into the office. For me, it typically takes about 20 minutes where we place these two temporary thin wires in the lower back that are attached to an external battery, and everything is secured to a patient's lower back with a bunch of tape. And we send patients home and give them anywhere from 3 days and up to a week. And what we're hoping for is over 50% improvement in symptoms to confirm that this device will work and this treatment will work for the patient. And if we get that 50% or more outcome in the patient's symptoms, then we would make a plan to place the full implant. And that trial has no risks, so it's a nice way of confirming that this treatment will help you without any risk, and kind of confirms for us that this treatment will be successful before going straight into the implant procedure. Once the trial has been successful and we're working on getting patients set up to have the full implant organized, the other decision for patients to make is what type of battery they want. And fortunately, choice is always nice. There are a couple of choices. The most recent battery that's become available is the Axonics R20, and that's a small rechargeable device that only requires charging really every 6 to 10 months, which is quite impressive. And the original rechargeable battery that Axonics developed, it was recharging once a month. So they really made advances on the newest battery. And for patients that really don't want to have to think about charging at all, there's also the Axonics F15 battery, which is truly recharge free and provides therapy for between 10 to 20 years, which is still quite a long duration of time, in a small, thin design for patient comfort. It is a bit larger of a battery than the Axonics R20, but in reality, both are small and thin enough that most patients don't feel the battery at all once it's been implanted. The only external aspect of this device that patients have available is this small pocket-sized remote control that does give patients control and allow them to increase or decrease the stimulation of the device, as well as toggle between a couple of different programs. But in reality, once patients have a program established that they're quite happy with, The goal is that most people would hardly ever need to even use that remote control, but just have it available if needed. And again, the nice thing with this device, which was unique to Axonics, is that it is MRI compatible. The implant does not need to be removed from the body for MRI scans if certain criteria are met. And it is approved for 1.5T and 3T full body scans. So what does the data shows? Well, ultimately in the studies, it shows that there is meaningful and lasting improvement in symptoms, with 93% of patients achieving clinically significant improvements in incontinence symptoms at 2 years. And 2 years after implant, over 90% of patients were satisfied with their results. 94% of patients reported being satisfied with Axonics therapy, and 93% would undergo the therapy, again with the same expected results. So quite a successful and durable, and again, long-term solution for a lot of patients, not just for overactive bladder, but fecal incontinence and urinary retention. And now to go into a bit more detail, Bulkamid, which again is one of the minimally invasive treatment options for stress urinary incontinence, which is that leakage with increasing abdominal pressure. What is Bulkamid? Bulkamid is a minimally invasive non-mesh alternative to treat stress urinary incontinence. It's a soft water-based gel that is clinically proven to help improve or cure stress incontinence. And we have a little video here that I'll play, just about a minute long, that goes in a bit more detail of how the Bulkamid injection therapy works.
Bulkamid can help provide the relief you've been longing for. The short, incision-free procedure typically takes less than 10 minutes. Involves 3 to 4 small injections of soft, water-based gel into the wall of the urethra to help prevent urine from leaking out of the bladder during day-to-day activities. It's safe, quick, and most patients can get back to your normal activities almost immediately.
So how does Bulkamid work? So Bulkamid is implanted to help cushion the urethra and restore proper seal, assisting the natural closing mechanism of the urethral sphincter. So similar to a facial filler, it remains in the body over time without causing an adverse reaction to the surrounding tissue. As you can see in the picture below, really once these cushions are formed, it does, as you can tell, narrow the opening to the bladder that provides bulk or resistance to help prevent the leakage from happening without really any risks of urinary retention is quite low or difficulty emptying, and overall risks are quite minimal with minimal recovery time. So what you need to know about Bulkamid: so it is safe and effective. 92% of women reported being cured or improved following treatment with Bulkamid. It's a simple procedure. It includes a series of 3 to 4 small injections that typically takes around 10 to 15 minutes in an outpatient setting under local anesthetic. This is a procedure that I offer in the office, and so patients come in, have the injection done, and leave all within a 30-minute time frame, and again can go on with their life without needing to take time off or recover from the procedure. And it provides long-lasting relief. So Bulkamid is clinically proven to deliver symptom relief out to 7 years.
Great. Thank you, Dr. Unterberg. It was a pleasure hearing from you and your experience treating patients suffering with bladder and bowel dysfunction. And thank you to everyone who was able to join. We really hope that you found the presentation beneficial. Thank you for joining us, and have a great rest of your evening.